Okay. Hi, everyone. Welcome to the last session for PD 101.
I was muted. Sorry. Hi, I'm Lyndsey. I'm a physical therapist, and I'll be presenting today as the third session covering the topic of exercise as medicine. And as Annie mentioned, just because of the flow of a webinar type presentation, if we could hold questions to the end, that would be great. Because otherwise it'll be a lot of choppy, audio and whatnot. So I love answering questions. Please feel free to ask them, but we'll just hold them to the end. So I'm going to go ahead and start sharing my screen here. Almost. Here we are. Okay. Okay. All right. So I mentioned my name is Lyndsey O'Keefe. I'm a physical therapist. I have a doctorate in physical therapy, and I'm a board certified neurologic clinical specialist. Those are all those letters after my name. Today we're going to cover the why, the how, and the what for exercise with Parkinson's disease. So again, like I mentioned, I have a doctorate in physical therapy. I'm a board certified clinical specialist in neurologic physical therapy, which covers Parkinson's disease, other neurodegenerative diseases, as well as brain injuries, including stroke, traumatic brain injuries, concussion, and things like that. I am a Power Moves certified therapist. We'll cover a little bit more about Power Moves and what that means in case you're not familiar a little bit later. I am a therapist practicing currently at Rehab Without Walls, which has it's a national organization of either outpatient clinical practice or also what they call home and community. So serving patients in their home or the surrounding communities, for instance, maybe meeting up at a trailhead, at a park, things like that. This location is based in Westminster, Colorado, and I'm also a lab instructor at the University of Colorado Anschutz campus in their Doctorate of Physical Therapy program. So today, things I hope to cover and for you guys to leave with a better understanding of is just briefly reviewing what Parkinson's disease is and how it affects movement. What does the research say about what exercise can do? What kinds of exercise is best and recommended, and how much of that is recommended? A few ideas of how to get started with some exercises right away if you're interested. And also an introduction for what physical therapy might look like if you were to go that route when you have Parkinson's disease, which of course, I'm a little biased there, but highly recommended to see physical therapy. All right, so Parkinson's disease, you'll see PD in most of my presentation now just to save space, but that's Parkinson's disease and movement. And so it's a decrease in dopamine. It affects a region of the brain called the basal ganglia, which is highlighted here in the brain in that image. So it's in the midbrain. What I'd like to make sure patients understand when they come to see me, especially if they're newly diagnosed, is that Parkinson's is a disease of motor control, meaning it is not necessarily a disease of strength. It's the disease of how you do that fine controlling of your movement. How do you initiate movement? How big your movement should be, and how you stop movement. And the four key symptoms of Parkinson's is bradykinesia, or slow movement, rigidity, which is stiffness, tremor, typically resting, and postural instability, basically just our way of saying balance problems. A patient with Parkinson's disease can have any number of these symptoms. Some may never develop the tremor, some may have a different onset of how strong each of these symptoms are, starting at different times in the disease, but those are the four key symptoms that we look for in diagnosis. So exercise is medicine. That's this national push from the Academy of Sports Science that really applies to everybody, but especially with Parkinson's disease. Exercise is neuroreparative, neuroprotective, and good for cognitive and emotional health. I mentioned the 4 key symptoms, the cardinal symptoms of Parkinson's disease. However, there are a lot of associated symptoms, including cognitive and emotional ones, such as depression, anxiety, decrease in motivation, sometimes cognitive decline, some dementias are associated with Parkinson's disease, and exercise can also affect those areas of your health. So we're looking at a really big picture, really the whole person, when we're talking about how good exercise can be, especially with Parkinson's disease. So I'll dive a little bit more into each of these with just a little bit of what the research says. And thanks to organizations, like Parkinson's Association of the Rockies, like Michael J. Fox Foundation, another one based in Colorado, but a national organization. I use their resources all the time when I lived in California as well. The Davis Finney Foundation, all of these ones that fund so much research. There's a lot that's out there about Parkinson's disease. So without going into too much nitty-gritty research detail, basically with the neuroparative side, exercise promotes neuronal survival and neuroplasticity. And neuroplasticity is, as the word sort of indicates, that it means that the neurons in your brain are plastic and they can change. And so what that means is when we exercise, we're optimizing the ability for that plastic aspect of, that changing ability of our neurons. And it increases your synaptic plasticity, meaning there's more connections between all your brain cells. Neurogenesis, meaning there's actually new brain cells being produced because of exercise. Angiogenesis, which means that there's more blood flow to these new connections and new nerve cells. And so we're really looking at, physiologic changes in the brain at the nerve cell level when we exercise. Most of these studies are done in mice. There's fewer done in humans at this time, and that's more related to just research difficulties, finding enough people to participate, finding, controls and all that sort of thing. So keep in mind, a lot of this is mice, but it's very, very promising. Another study showed that endurance exercise reduced the motor and gait behaviors that are typical with Parkinson's disease. Again, it's a mouse study, but they're looking at mice going through a maze, and all the mice were induced essentially with a Parkinson's type disease. The ones that participated in endurance exercise showed significant changes in those behaviors, and the walking changes or different movement patterns. The ones who had a sedentary lifestyle, or were not put through any sort of endurance exercise, did not show those changes. So it was not, it was significant that the exercise made the difference. Neuroprotective is really key because Parkinson's disease is a neurodegenerative disease, meaning that it does worsen over time and it progresses. And at this point, we don't have a cure. So we really want to protect those brain cells as early as possible upon diagnosis. And exercise is really, really critical in doing so. So one study showed, and this was actually with people, which is nice, not mice and rats. One study showed that people with Parkinson's disease who exercise regularly, that's a key word there, regularly, for 2.5 hours a week, which may sound like a big number, but spaced over a week, we're looking at about 30 minutes a day. That's not too bad. Had a smaller decline in mobility and quality of life over 2 years. We're also, again, looking at back to our animal studies here, that there's exercise-related protection when we call dopaminergic neurotoxins. Great Scrabble word. But the dopaminergic neurotoxins, basically the toxins that affect that those dopamine cells. And again, going back to the key diagnosis, the key meaning of what Parkinson's disease is a decrease in dopamine. So direct exercise-related protection of those dopamines. So it's not just the whole brain, it is that specific to the disease process. Also, the mice that exercised were shown to use dopamine more efficiently, which is awesome. So even if Parkinson's disease has already decreased your production of dopamine and your ability to use it, when you exercise, it's going to make your brain be able to use what's left of your dopamine more efficiently. Also, it improves efficiency by modifying the areas of the brain where dopamine signals are received. So basically the production of dopamine is less, but the area that it's, again, those areas that are going to use that dopamine is going to be that much more primed to do so. And then, of course, like I said, I mean, a lot of studies have shown what exercise can do for cognition in any aging adult, and that's true also of Parkinson's disease. And emotional health, I mentioned that that a lot of associated emotional symptoms of Parkinson's are things like depression and anxiety, which exercise and endorphins can do a lot for. On a more functional level, exercise can optimize independence, optimize participation, prevent falls, and preserve physical capacity. Independence, that is perhaps the one thing that is consistent with every single patient that walks in my clinic door, is they want to be the person they always were. They want to be independent and they want to participate in things that matter to them. That's different for each person, of course, what that participation means, but exercise can help you get, things like maybe hiking, biking, or things like gardening, or even just things like I want to participate in being, in keeping up my house and being able to do my laundry and make a meal, play with my kids and grandchildren or pets. Any of that level of independence and participation is, as a physical therapist, what I'm most interested in is what makes that person in front of me them, and how can I help them continue to be that person? And exercise is how we do it. It prevents falls. That's huge from a safety perspective, from a secondary deconditioning issue. If you fall and then you might hurt yourself, and that puts you out of commission for a while. You might fall and then get too afraid to move as much anymore. And so we really want to prevent those first falls from ever happening and improve your balance, which we'll talk more about a little bit more specifically later. Preserving physical capacity is also something I like to highlight with patients. Like I mentioned in the beginning, Parkinson's is not necessarily a disease of strength. It's a different part of your brain that actually produces muscular strength and your ability to contract your muscles efficiently. However, when you have a disease like Parkinson's that makes movement more difficult, or perhaps you're more unsteady, like I mentioned, that fear becomes an issue, then that secondary deconditioning, that weakness now happens because of a change in movement patterns or movement frequencies or intensity. And so there is a secondary effect of often weakness happening. And of course, we know exercise helps with weakness, and we can strengthen, which again, we'll discuss a little bit more specifically about how to strengthen muscles and what the recommendations are. So all of these exercise guidelines are for any human being. Anyone that walks in the door is recommended to have this general guideline of exercise, which is aerobic exercise, strength training, balance work, and flexibility. Aerobic exercise is what gets your blood pumping. It's thinking of getting your heart rate up, getting your breathing a little going, maybe sweating a little. Those recommendations are 150 minutes of moderate intensity per week, or 75 minutes of vigorous per week. Again, that seems like so much, but 150 minutes, we're looking at just over 30 minutes a day per week, if we look on a week-long basis. The other thing to note is when we're looking at a week-long basis of all of these recommendations, what they did find, which was really great news for I think most people, is it's not a daily. It's great if you do things daily, and some things you do, flexibility, balance, those are great to work on daily from a learning perspective, but the effect of especially aerobic exercise on a weekly basis is the same. So if you did 150 minutes of moderate intensity in one day, because you're a weekend warrior and you go out on your Saturday hike and and you burn all those minutes out in a day, it's the same benefit as if you spaced out those 150 minutes over the week. And so again, people with different schedules, different, maybe you have caretaking that can only bring you to a gym, or you don't drive and you need somebody that, to take you to that trailhead, for instance, or the park to go for a walk. If you can really make those recommendations work for you. For strength training, that's when we're contracting our muscles, we're making them stronger, oftentimes with resistance. Resistance might be your own body weight. It might be a dumbbell at the gym. It might be a laundry basket full of clothes, but anything that's resistance, that's makes those muscles work a little bit harder. That recommendation is about 2 days per week or more, depending on how you divvy it up. Again, each of these has their own bit more specific slide in a bit. Balance training, we want to reduce the wobbles, we want to prevent falls. That recommendation is officially 3 days per week or more. If you're my patient, it's every day, a little bit, even if it's for 2 minutes while your coffee brews or you brush your teeth, or you're waiting for that phone call back or something like that. If a little bit every day really matters, but also at least 3 days per week is fantastic. And flexibility is a little a day. You don't want to. You spend you could stretch for an hour one day, but if you spend the whole next day sitting down and never moving, we're not. That's where that daily recommendation really does make a difference. So a little bit of flexibility. We're not looking for anybody to join Cirque du Soleil and do a split, but just a little bit of stretching, especially since in Parkinson's disease, rigidity is one of the key symptoms. Okay, so aerobic exercise, we're talking again about anything that's getting your heart rate up, getting your breathing a little bit heavier, maybe sweating. I don't tend to use sweating and heart rate as much of an indicator, because based on the individual, what medications they may be on, their cardiovascular history, they may not have the ability to sweat very much. They may not have the ability to have their heart rate go to a certain level. But I like this chart on the right there of the screen is talking more about how you feel, what we call your rate of perceived exertion, which is that RPE number you see in the words over there, the 5 to 6 RPE, 7 to 8 RPE. That's again your rate of perceived exertion. That is what you telling me how hard you think you're working. And that's also then I like more of what this chart refers to as how hard you're breathing. And so, for instance, if you look at number 1, it's a scale 1 to 10. 1 is I'm watching TV and eating bonbons. You're not working hard at all. A 10 is, oh my God, I'm dead, or I'm about to be. So when we're looking at somewhere in between, that's where that moderate or vigorous comes in. So that 150 minutes per week of moderate is somewhere in that 5 to 6 RPE, where you can still talk, but not in a whole story, not in multiple sentences at a time, because you're a little bit breathless. So for instance, if that's your goal, is to work at that moderate intensity, and I walked in and said, how are you doing? And you told me what you did every minute of the day, what you ate for breakfast, what your plans are for dinner, and what your weekend's going to look like, all without stopping to catch your breath, you're probably not in that moderate intensity level. If you couldn't talk at all because you're so out of breath, you're also no longer in that moderate intensity. That 75 minutes per week of vigorous work is that 7 to 8. So again, you can see on that chart what that looks like. It's 1 to 2 words at a time before you're really catching your breath. And again, this is different for each person. My 8 out of 10 on the scale is going to be different than anybody else because it's, again, my own perceived exertion. How hard do I feel I'm working? That also changes each day. If you're recovering from an acute illness, you might feel like you're working much harder before a point where you ordinarily would feel like you're working that hard. Or if you had a great night's sleep and things are really going your way, you might be able to work even harder, or push yourself even more before you feel like you're at that level of perceived exertion. Aerobic exercise can be any form. So it's at the very top, what kind, anything? That's a question I get so often is, what's best? Walking, swimming? I heard biking's really good. I like to dance. Is that okay? It's all wonderful, because whatever you enjoy is what you're going to do, and that's the key. And so anything you enjoy that gets that heart rate up, it might be marching in place in your kitchen. It might be dancing to the radio. It's anything that's, again, that aspect of feeling like you're working hard, you're getting a little bit breathless, and perhaps your heart rate's elevated, perhaps you're sweating. It does have to be, though, at least 10 minutes at a time in order for it to have any of those benefits that we know aerobic exercise can have. And so again, if it's, going up the stairs in your home just to get to that next level and then you stop, while that is activity and is certainly good for you in many other ways, it's not considered aerobic exercise in the way that we're looking at these recommendations. And for specific to Parkinson's disease, what we know from, again, many studies is that more is better and intensity matters. So the more is better. What we're looking at, there's a really great study I like to reference that, again, looked at mice. They induced a Parkinson's type injury into their brains, and then they put them on treadmills. And so the mice that ran at 18,000 revolutions per day compared to the mice that were running at 6,000 revolutions per day. So again, still moving at that 6,000 per day, but not as much as that 18,000. The 18,000 revolutions per day did have that neuroprotective effect that we're looking for that I mentioned, that we talked about earlier. The mice running at 6,000 revolutions per day did not show that. So in order to get that neuroprotective effect of exercise, more is better. Also, more on a larger time frame is also better. In a separate experiment, it did, again, looking at that 18,000 revolutions per day, mice that continued that regimen for 2 to 3 months were protected. The ones who stopped after 1 month were not. So I kind of joke with some patients that, unfortunately, exercise is not like a piggy bank. You don't get to put it all in a month and then stop and hope that it still helps you later. You really have to keep it going with that consistent exercise routine. A week here or there that you miss, we're all human. We go on trips, we get sick, the holidays happen, whatever the case may be, that's going to happen. But we really want to make a consistent effort here, which is also why finding something you enjoy is key. The intensity also matters. So with a human study now, looking at something called the UPDRS, which is a big battery of tests that your neurologist might have performed on you. There's a motor score, so very specifically just looking at the movement aspect. What they looked at is they had 128 subjects within 5 years of diagnosis, so relatively early in the disease process. They all exercised for 3 days a week. They either did 80 to 85% of their maximum heart rate, which just was basically that 7 to 8, that vigorous intensity, that 60 to 65% maximum heart rate, kind of more that low to moderate, or what we call usual care, which is just sort of your daily life. You walk around the house, you go up the stairs sometimes, you do your laundry, empty the dishwasher, normal life. In a 6-month period, what we want to see is on that UPDRS score, a lower amount of change is better. So keep that in mind, that we want to see less change. That means less progression of the disease. The group that exercised at the highest intensity level only changed 0.2. The low to moderate intensity level changed 2 scores, so a 10 times difference. The usual care groups changed 3.2, so significant difference on the group that really exercised at an intense in an intense way versus just that usual care, usual daily activities. Another study recently it just came out in 2021, in humans, again, this was huge because we finally saw some structural physiologic changes in humans as opposed to seeing them in mice. There was altered brain structure and function from aerobic exercise, but not from stretching alone. So I mentioned stretching's good, and we'll talk more. There's some really key parts of stretching that are super important, but that alone is not going to alter the brain structure and function like doing aerobic exercise, especially when we're looking at how much you're doing and how hard you're working. So that was a really intense slide, lots of information, but hopefully that also brings home how important this is. Strength training, at least 2 days per week. And that changes based on how you do it. So what we don't want is to do really intense strength training of the same muscle group every single day. So if you're someone who wants to just do your whole body all at once and then only do it 2 days per week, great, that's fantastic. If you're someone who wants to do smaller bits at a time and do just your legs one day, your arms the next day, then you might do more frequently throughout the week because you're hitting each one on a different day. I tend to have patients focus on functional movements. Unless you really love going to the gym, lifting your weights, doing individual things, doing functional movements are more functional, obviously. It's doing things like standing up from a chair and sitting back down. But also you're working multiple muscle groups at once, so you're a bit more efficient, more bang for your buck. Nothing wrong though with doing individuals exercises from a strength perspective. So examples of functional movements include sit to stand, sort of like a squat, but again, it's a little safer. You get that chair behind you. Plus, how many times do we have to get up from some sort of seated position throughout the day? It's super functional. A push-up on the walls, totally appropriate. Maybe a little more challenge from your countertop would be great. Working on a lot of upper body and shoulder strength for lifting, carrying, a lot of household tasks, going to help with your posture, keeping you more upright. Marching is a great strength training. You can do that from a seated position or standing. When you're strengthening through a marching exercise, you're strengthening the front of your hip muscles and your legs that are going to lift that foot up and help you take that bigger step that people often notice is difficult when you have Parkinson's. Aiming for 3 sets of 10 repetitions. That is a nice rule to know how hard you're working and if it's appropriate. In order to be a strengthening exercise, you do have to challenge your muscles. That's how they get stronger. They have to be strong enough. They have to be challenged enough for the brain to say, hold on, I want to be better at this. Let me create more muscle there and get stronger. And so if you can do 10 repetitions, rest a little bit and do 3 sets of that, and a little is like a minute or 2. And that feels like, okay, I definitely did something. There's a little bit going on in that muscle. There's some heat building, maybe a little bit of fatigue and soreness, but I'm not, wobbling and can't stand anymore. Or it also doesn't feel like I could do 4,000 more repetitions. You're in that sweet spot of challenging yourself enough. Discomfort and fatigue is absolutely normal if you are doing a strengthening exercise. Pain is not. So this is not a no pain, no gain, especially, if you're working with a trainer, either formal or informal, maybe just you have a family member that's helping you through some exercise. If you have a personal trainer, you have a physical therapist working with you, please do speak up. If you say, especially something like a squat, very common to have knee pain. That's not normal. A little bit of discomfort, maybe, but if you're saying, if I'm feeling sharp pains, I'm feeling, shooting pains, things like that, not normal, we can modify that exercise. A 24-hour rule is great to follow when you're thinking of how fatigued should that muscle be. So for instance, you do your sit to stands or some sort of squat, at lunchtime on Tuesday. By lunchtime on Wednesday, you should be feeling mostly back to normal. Maybe still a little bit. If by lunchtime on Wednesday, or certainly dinner time Wednesday, into Thursday, past that 24-hour mark, you're still feeling like, oh my gosh, I can barely move, I'm so sore. you probably overdid it. And next time you got to scale it back a little bit. Balance. Like I mentioned, daily is ideal, but the official recommendations are at least 3 times per week. With balance, if you don't use it, you lose it. And so I say this pertaining to patients who often come to me and say, well, I walk, I do, I maybe stretch a little bit. They're certainly active and exercising, but they don't specifically work on balancing skills, then it's not going to be as effective at improving their balance. It is something you have to very specifically practice because balance is extremely complex. There's a lot of systems in the body that factor in when you're with balance. There's a lot that could be at play. And if you're not working on those specific things, then it's not going to improve on your overall balance and stability. A lot of options when you're looking at balancing, where your feet are positioned. Are they close together? Can you put them heel to toe or tandem, like imagine being on a tightrope, or a single leg? But there's a lot of options. People say, well, I can't stand on one foot. Well, that's fine. Not everybody can, but we can still work on other ways of improving your balance. Your eyes could be either open to really give you a lot of visual input. Closing them is extremely challenging, but super important to practice, especially if you're somebody who, I'm great balancing during the day, but if I get up at night and the lights are off, I'm way off balance. Your vision should really only play in as 10% of what your body uses to keep you balanced. Meaning if when you close your eyes or the lights are out or you forgot your glasses across the room and your vision is compromised, it should not affect your balance more than 10% of normal. For most people, that's not true. You close your eyes and you're suddenly way off balance. That means there's some things to work on. Your surface could change if you're on a firm surface, just like feet on the floor on the hardwood or tile, versus a soft surface, even a really plush carpet. Maybe in a clinic you might be standing on a piece of foam, maybe even as far as something that's filled with air. That's going to affect your balance differently. At home, if patients are doing this at home, sometimes things like a pillow or a couch cushion on the floor can be a nice soft surface to work on. Here in Colorado and the surrounding areas, we're looking at different terrain, especially as the weather's changing. And so practicing on different surfaces is really important. Your hands might be holding on really tight for dear life because you're really off balance. You might be arms straight out in front of you, maybe arms crossed. You might be able to move your arms, to challenge yourself a little bit more. So there's a lot of factors of how we can change your balance, how we can change the challenge in a balance exercise. And especially when you're seeing some exercise professional, a personal trainer or a physical therapist, that's where we can really tune in. And that's what we're trained to do, is to see what in particular is your challenge and how can we attack that and how can we get that better. In general, a balance exercise should be difficult but doable. If you are not wobbling, if it is easy to hold that position in a balance exercise, it is not a balance exercise. You're just doing what you're already good at, which is fun, but not really efficient. It has to be difficult. It also has to be doable though. If you, for instance, want to work on your balance and you pick up one foot to just stand on a single leg and you immediately lose your balance and have to hold on and catch yourself, that's also no longer a safe or ideal balance exercise for 2 reasons. It's not safe. We don't want you to hurt yourself. But also, if you're not holding that position long enough to actually work on your balance because you're just falling out of it, then you have no opportunity to actually learn of how to improve that balance. Your brain has none of that drive to really say, how can I solve that problem? Flexibility, a little bit of daily mobility is fantastic. Again, we're not looking to put your foot behind your head, to do a split, nothing like that. We're just looking at gentle holds, finding something that feels like a slight pull and hold it for 30 to 60 seconds. If it is not tolerable, if you feel like that 30 to 60 seconds is painful, is unbearable, I can't wait to get out of the stretch, then you've done it a little bit too far. You can back off, and just that really gentle pull is what we're looking for. Whole body movements are great. So working on your legs, your arms, postural exercises, spinal mobility. There'll be a whole slide later on spinal mobility. So lots of options. Touching your toe is great, like the picture shows. Doing some arm stretches, some chest stretches, especially if your tendency is to be hunched forward like that. So we really want to open up through here. Rotation and twisting movements gently. Again, these are general recommendations. If you have had a doctor that for some reason from an injury or surgery says you're not allowed to twist, listen to them. But otherwise, rotation has been shown to be really effective in reducing spinal rigidity, again, one of those 4 key symptoms of Parkinson's. So how can we get started? Of course, there's a disclaimer. Keep in mind these are general recommendations, and they may not be right for your body. If you have any concerns about your ability to perform these exercises, please consult with either a physical therapist or your doctor. Axial mobility. Axis refers to our spine. So this axial mobility program was developed by physical therapists out of the University of Colorado. And we're looking at range of motion and relaxation. These were also looked at for patients, not patients, but anybody, especially aging adults, as they get a little bit stiffer. And a lot of them are performed in this position that you see in this picture, what we call the hooked lying position. So they're lying down with their knees in a hooked shape. That's what we call hooked lying. And so what they see is that increased spinal mobility improves posture. If you can be hunched over like this. If your spine can't stretch back to that straight position, you can have all the intention of having great posture, but you're just not going to be able to do it. So that mobility is important for posture, important for functional mobility. So things we call transfers, anytime you're moving position. So sitting to standing, getting out of bed, rolling over, bending down so that you can get onto the floor. Any of those transfers, you have to have mobility and range of motion in your spine to do so. Balance is, spinal mobility has been shown to improve your balance because, again, if you can't bend forward at the spine to reach and pick something up from the floor, for instance, then your weight gets shifted a different way, you get off balance, you might fall. Your ability to catch yourself, if you start to fall backwards, you have to be able to extend and really catch yourself and readjust your posture in response to that loss of balance. And if your spine is stiff and can't achieve that quick change and quick movement, then you're more likely to fall because of that loss of balance. We're also looking at relaxation. So the first thing on this axial mobility list of quote unquote exercises is just deep breathing. You may have heard of diaphragmatic breathing. Your diaphragm is the bottom of your rib cage, and it's what pushes your belly out as you inhale, as opposed to breathing up into your chest. We want to see that expansion of the belly with an inhale. And that deep breathing promotes relaxation of the nervous system, which improves efficiency of your muscles, and is used separately as a strategy for people who have freezing of gait. So real quick aside, freezing of gait, haven't talked about it much. It's a, excuse me. It's common in Parkinson's disease. It is not a key symptom because not everybody develops it, but it's that sensation of your feet being stuck to the floor and you can't move. We really, it's beyond a brain thought process of saying, like, I know I need to move, I physically can't lift my foot right now for some reason, as we call freezing of gait. And so if that is something that develops, then a key strategy that we use in physical therapy starts with relaxing, taking a deep breath, calming the nervous system down in a way of prepping it to then overcome that sensation of freezing. So your first exercise you can do is to lie down and deep breathe. It's the best exercise anybody could recommend. So you would lie in this position, like shown in the picture. I recommend hands on belly, upper belly, just below your rib cage, as a cue of where you want to feel your body rising and falling with your inhale and exhale. So again, we're looking to get rid of that kind of breathing way up here in the chest, and really that the belly is relying on your back in that position. Your belly would go up towards the ceiling as you inhale, and sink back down gently as you exhale. Another thing with deep breathing, you might, if you participate in any yoga, meditation, things like that, is long inhale and long exhale. You might even count it. You might breathe in for the count of 4 and out for the count of 4. And that's all that exercise is. Believe it or not, just by doing that, you're expanding your rib cage. Your rib cage attaches to your spine, so you're increasing your spinal mobility. You're decreasing that overdrive of the nervous system that can happen with the stress of a diagnosis like Parkinson's or daily life. And again, for certain symptoms of Parkinson's, especially things like freezing, we need to calm that nervous system down to be able to then promote the proper movement that we're looking for. Knee rotation is that's the same position shown, and you're just going to let your knees fall to one side and the other. So thinking of windshield wipers, very gentle. It's going to rotate through your hips, just a little bit through your low back. If this is uncomfortable for your any part, for your knees, your hips, your back, something to go all the way to the ground on one side, setting up pillows on either side as a way of stopping part way and then back to the other side, you can still achieve that same movement, that same benefit without going into a spot where your body's just not comfortable. From the same position, reaching arms up overhead. So just like it sounds, all you're doing is reaching your arms up, trying to get them to touch, in this case, the behind your head because you're lying on your back, trying to get them to that spot. They might not go that far, that's okay. But when you're extending your arms up overhead, you're again extending through the whole spine because of the attachments of your shoulder blade to your spine. And you're going to be, helping that extension, that straightening to combat that hunched forward compressed posture. Double rotation is basically combining those two. So your knees will go to a side and your arms will go up overhead. Your knees come back up, your hands come back down. You're going kind of back and forth. It's a little bit of a rub your belly, pat your head situation. A little difficulty with coordination, but I encourage everybody to give these a try. You can do them on the floor. You can certainly do them on your bed if you're not comfortable getting on and off the floor. It's a great way to start or end the day with a little bit of relaxation, a little bit of mobility. The power moves. So I mentioned I'm a Power Move certified therapist. PWR stands for Parkinson's Wellness Recovery. And then like the exclamation mark. Everything's very exciting and big and loud and in this type of exercise routine. So this is a really common type of exercise, either individual exercise, group exercise, classes to follow these power moves. In fact, Parkinson's Association of the Rockies hosts power moves courses. And I really encourage everyone to check one out if you can. So these were developed by Becky Farley, who is the godmother of physical therapy for Parkinson's disease. It's what she's dedicated her entire career to. You may have heard the LSVT Big or LSVT Loud programs. She did the big, the movement part of it. The loud is for your voice. The big was her thing. She then moved on to develop the power moves. And the whole emphasis of these power moves is increasing the amplitude of movement and the intensity of movement. And the nice thing about power moves is it's really adaptable to your level and your ability. As you can see here, there's 4 different positions. Actually, there's 5 different positions total in there, but the bottom one shows all 5. So you're lying on your stomach, lying on your back. Oh no, my screen was cut off. It does show all 5 for the top one. Sorry about that. So yeah, lying on your stomach, lying on your back. So even if you are not somebody who's up and standing and exercising, and you even lying on your own bed or certainly on the floor if you can, if that's available to you, but even just lying down, there's a lot you can do to exercise and focus on your body's wellness and your movement. Kneeling, which is fantastic if you're somebody who likes to get on and off the floor or ground for things like gardening, housework, playing with pets or children or grandchildren. So kneeling is a great position to exercise in. Sitting, so again, maybe I'm not too sure, my balance isn't great. I don't think I want to be standing and moving for a class quite yet. all of these can be done in a seated position and still have amazing benefit. Or of course you can do all the way in standing, and you can move in between them. So there's a lot that you can do with these power moves, and the group classes are awesome. I highly recommend them. Otherwise, a lot of physical therapists who treat Parkinson's disease will be familiar with them and can also incorporate parts of it into treatment. So real quick, I just want to show one of them that you can start doing today for posture. So you're going to be sitting, and I can't see my screen anymore, so hopefully y'all can still see me here. But it's going to be demonstrating that seated position in the top row of pictures here. So it's working on posture, and then power moves, it's called powering up. So you're going to be sitting with your feet nice and wide. Again, everything is big, everything is large amplitude, even where your feet are positioned, what your fingers are doing, you're going to be stretching. You might even incorporate, shouting that power up and really being loud about it. Everything, excuse me, the harder your body works, everywhere from your fingers to your toes to your voice, is going to increase the efficiency of these movements. So you're going to bend down and then power up, get as straight in the spine as you can, straighten your arms as much as you can, stretch your fingers out, squeeze your shoulder blades together, really get as straight as you can. And then you're just going to repeat that. You're stretching your hips and your back, you're stretching your shoulders, you're strengthening your spinal muscles. And it's also the first component of getting up out of a chair if that's something that becomes difficult for you. The first thing I teach patients is you've got to get your nose over your toes, which means you got to lean forward and then power up to get yourself up to standing. So these power moves are both exercise, but also super functional strategies. Oops. There we go. Okay, so a few more exercises you can get started with today. Sit to stand. Mention how functional this exercise is. We're working on multiple body parts. We're working on a very important movement, getting up out of a chair, getting up out of the car, getting off the toilet, off the couch. And there's a lot of times in the day we're working in this sit to stand type movement. So you can see the picture, sitting, standing, back and forth. A lot of words there to describe it basically. And so a lot of what I want to focus on is how we modify this if this isn't something that you're able to do at this time. You can use the supportive armrests if you need to do this safely. You can maybe instead push your hands off your knees, maybe just use a little bit of lift from your hands and then stand the rest of the way up. It doesn't have to be exactly like what that picture looks like for it to be worth it. It just has to be challenging for you. Really challenging would be arms over your chest. So you get no extra momentum and weight of your arms reaching forward to help you get up. The other thing that's important is to slowly sit back down. If you don't control the way back down, then gravity did the work and you didn't. And we want to work both ways. We want to get all the exercise we can squeeze from this one movement. And so slowly sitting back down, again, often tell patients, pretend you're not sure if the chair is actually there. That's how slowly you want to sit down. But the nice thing about this exercise is, of course, the chair is there. And so if you suddenly lose that control, worst case, you just sit back down. No harm, no foul. But if you really try and control that descent, then you get that eccentric strengthening, which, and just a physiologic term of how your muscles are working, but a way that they need to work in order to, catch yourself off balance. If you're off balance, in order to, certain parts of walking require that slow control of movement. And again, 10 times, that 3 sets is what we're looking for each strengthening exercise. Heel raises. This working on what we call your gastroc muscle or your calf muscle, the bottom back part of your leg. These are great because your calf muscles play a huge role in balance. They also are the key muscle when we're looking at the difference in walking speed, believe it or not, is those calf muscles. So we can get those firing up, we can get you walking a little bit faster. So you're going to stand using some sort of surface like a countertop, maybe the back of a chair. or a high table, something like that. Feet are spaced apart, and then you're going to lift up onto your toes. Lift those heels up as high as you can. Hold for about a second, and then again, that just like we talked about in sit to stand, slowly lower back down. If you want an extra challenge for balance, when you're holding that 1 second with your heels up, see if you can lift your hands just for a second. Maybe you lift your hands the whole time up and down. That's again, just an added bonus, and it's whatever works for you and it feels safe. And 10 times, 3 sets, that's what we're looking for in a strength exercise. So there's just 2 very basic examples of strengthening. We talked about some power moves, some axial mobility, so some stretching, some balance, some functional mobility, some strengthening, all with 4 or 5 moves. If you really want to condense that program for yourself, those are some great ways to get started. We didn't talk about anything specific for aerobic because, like I said, that's really anything you're doing that's getting that that breath, not quite breathless, but getting towards breathless, getting that difficulty breathing, maybe sweating, maybe heart rate up. So physical therapy now for Parkinson's disease, what this might look like. So our goal in physical therapy is for every person who is diagnosed with Parkinson's disease to see a physical therapist. And that's not just because we want the extra work. It's because of how effective it can be. Like in the very beginning, we talked about it can be effective in repairing what's lost, but that happens most often early in the disease. So I worked in a clinic one time where we had the goal of within 10 days of diagnosis, you are seeing a physical therapist. That is a lofty goal, not realistic for everybody, but again, speaks to how important this is, especially to start things early. So what it might look like for those of you unfamiliar with physical therapy, it starts with an examination and evaluation. So there's various tests and measures that your physical therapist would perform on your first visit, maybe spaced out first few visits, depending on how many tests they want to do, how much background information there needs to gather, how long appointment times are, all that stuff. But lots and lots of choices looking at things like your strength, your walking, your balance, your functional mobility, so how well you're getting off the floor, out of bed, out of a chair, up and down stairs, making turns while you walk. Lots we look at very specifically. Education is the most important thing that I do on a first visit with a patient newly diagnosed with Parkinson's disease, because they need to know all the stuff that you guys just learned about why I'm going to push them so hard to exercise. They need to leave there with, they need to believe in what I'm trying to get them to do. Otherwise, we're just gonna, what's the point, right? If they only come to me once or twice a week and they don't do any exercise on their own, we're not really getting all that benefit. So that education component is really key. But you guys could all go to your physical therapist and say, I already attended a lecture. I know, I can tell you all why I want to exercise so much and what the benefits are. And another thing will be home exercises. So this will be modified again to your level, to your interest, to what your schedule might look like, but you'll definitely have some homework. And then treatment options and moving forward, what the whole treatment course will look like, whether they recommend seeing you 2 to 3 times a week, 1 time a week, maybe 1 time every other week, maybe even just 1 time every month. Will be based on all of those things, what the test and measures look like, what your schedule is like. If you say I don't want anybody to leave right now feeling like I can't go see a physical therapist because I can't commit to 3 times a week. If you told your therapist I really can only come once every other week, then it's the job of that physical therapist to make that work for you, to adjust the home program, to adjust what the exercises in the session look like, to make that schedule work. So it's patient-centered, basically, as a big part of it, is what's going to work for you, but also what do you need to work on? What functionally are you having difficulty with? So if you are planning to see a physical therapist for the first time, I encourage you to have a list. Go in and say, I've noticed I am having a harder time getting off the couch than I used to, or I walk around the house great, but as soon as I have to go across, the grass in my yard, I feel a lot more off balance. Another thing you might want to consider is asking your friends and family or anyone in your life that has observed you move what they notice. Sometimes you may not notice what's difficult, but I oftentimes will have spouses of patients say, actually, you're doing that differently than you used to. And for the patient, it's just become their new normal and they're not aware of it. And the nice thing about physical therapy and how it's been developed for Parkinson's disease is that it's really appropriate for any level of the disease and any ability level. So I have had newly diagnosed patients with Parkinson's who are still running marathons, and we still have things to work on, and it's more focused on prevention of things getting worse and more about fine-tuning what they're doing on their own. Maybe they're running marathons for example, but they're not working on balance, or they're not really working on their arm strength because they're running so much. So we might adjust a little bit, and it's really the earlier in the disease, much more we're going to focus on that vigorous exercise, because we want to capitalize on the brain's ability to repair and prevent worsening of the disease, and repair what little has been affected so far. With moderate stages of the disease, we might start to shift more into compensatory. So instead of repairing a lot, we're kind of looking at what the body's currently able to do, and it might be a little different, but we're gonna capitalize on what's still there, basically. And so it might look a little different than what normal optimal movement would be, but the goal is function. The goal is still doing the task that you want to do, and how we're going to use your body's ability to do so. And in more severe and late stages of the disease, we're looking at a lot of prevention of secondary things. So maybe they're no longer walking independently, but we still want to make sure that they don't lose their range of motion, that they don't develop bed sores, that they don't lose any muscle strength in their upper body, for example, so that they can still maybe push a wheelchair if they need to, or lift their walker in and out of the car. So there's a lot to work on regardless of stage of disease. Really nice new things that is new since I started practicing physical therapy 9 years ago is that Medicare now covers maintenance care, which is a huge development, because for a long time, if we were seeing a patient who has Medicare insurance, and we had to prove that we were improving, that the patient had the ability to improve and was doing so in order for that Medicare to keep paying. Now they cover maintenance. And so even if you are at a stage in the disease where perhaps that brain is really having a hard time in getting new skills, but we can maintain what you currently have, and that is, again, so important for any level of ability and any level of disease, that is now still covered under Medicare. So if for some reason you have a physical therapist or doctor that's not aware of that change, I encourage you to advocate for yourself and say, hey, actually, maintenance, I'd like maintenance therapy, and that's something that my insurance will now do. So besides starting on some exercise today, I also encourage everybody to create a team, a medical team of your medical doctor, a physical therapist, perhaps an occupational therapist, a speech language pathologist. So briefly, occupational therapy works on much more focused on daily tasks, fine motor controls, especially if you have hand tremors, using adaptive tools to help, doing different hand exercises. A speech language pathologist can be helpful if you develop swallowing difficulties or your speech becomes affected. A lot of times it's quieter voices, maybe a little vocal tremor. Speech language pathologist or speech therapist can help with that. There is a tool on the APTA website, the American Physical Therapy Academy, that's Find a PT, and that way you can type in especially in your zip code. You can even type in if you're looking for a neurologic specialist, which are rare, so don't be too discouraged if there isn't one, but you can still look for someone in your area, especially if they may not be a certified neurologic specialist, but they may have listed that neurology is one of their areas of interest. Your friends and family are a huge part of your team. They're going to help you stay focused, stay motivated, maybe exercise with you, drive you to appointments if needed. Really include your whole village to really help you. There's a lot of community resources, community exercise groups. If you're someone who you're social, you want to exercise with other people, maybe you just don't have resources at home to do it. There's group exercises, especially through PAR, and support groups talking about what's difficult, finding out what other people are finding that's helpful to them, not just from a physical standpoint, but also from emotional and cognitive standpoint. And that you may even find someone who becomes a walking buddy. So really encourage you to use all those resources available to you. So I'll open it up to questions. I think there's the option of either kind of raising your hand to ask in person or typing it in, and then Annie will read the question to me.
See. No questions as of now.
All right.
Oh. All right, Eugene has a question. Let me.
Okay.
Wait. See if you can unmute yourself, Eugene.
Yes, can you hear me?
Yes, I can.
Yes. This question pertains to strengthening of the body, the total body, weights in particular, and the increase of the weights with respect to what one can do, and also thermobands, the usefulness of those two pieces of equipment for strengthening and other benefits that you might allude to, if you would, please.
Sure. Yeah. So as I mentioned with strengthening, that some sort of resistance is necessary, and that may just be your body weight. So things like your heel raises, your whole body is the resistance to that. But if you're doing upper body exercises, just bending your elbows isn't really going to be a bicep curl unless you're holding something in your hand. And so yeah, a dumbbell weight, they're pretty widely available in a lot of major retail stores. I don't want to advertise for anything in particular, but Walmart's, Targets, things like that will have small sets, maybe 3 pounds or 5 pounds. So definitely useful. You're looking for the amount of weight you want to use is whatever helps you fall into that 3 sets of 10 rule that I mentioned for strengthening, which means if I'm using 2 pound weight and I can do 50 bicep curls without feeling much of anything, that's not enough weight. If I want to find the amount of weight where I'm going to do 10 of them, feel like, all right, little rest, catch, shake it out, 10 more, shake it out, 10 more. And then by the end of that 3rd set, should feel like, yep, definitely worked that muscle. It's feeling a little warm, a little tired. Then that's the appropriate amount of weight. TheraBands is, I think, what you were referring to, the stretchy elastic bands.
Yes.
Yeah, those are also fantastic. A really great option if you are exercising at home and you don't want to collect all the dumbbell weights. There's a lot of modifications of basically just how tight you're holding it, or how many times you wrap it around, to make it more or less resistance. And the nice thing too about TheraBands is you can exercise in a lot of different positions, because you can sort of change where the line of pull is coming from, essentially, to make that resistance work. So I'm a huge fan of TheraBands for sure.
Thank you.
Mm-hmm.
All right, Kevin, I'm going to unmute you.
Perfect.
Go ahead, Kevin.
Okay, great. My question regards PT. I've been with physical therapists quite a bit just before diagnosis, and they were great, but they were $80 an hour for not dedicated time. And I was looking for a personal trainer or place to get personal trainer who's cognitive of what the PT therapists are going to recommend and specialize in Parkinson. I'm really reluctant to join a gym, pay a fortune for some mediocre personal trainers. But do you have any recommendations of how to get a good personal trainer that would understand Parkinson's?
That's a great question. I would ask your physical therapist if you still have contact with them. Where I've practiced throughout the years, most clinics, there's been some outreach from personal trainers coming in to say, hey, just so you guys know, I specialize in this, or I'm really, this is the type of patients that, or type of clients that I see. So I would ask the physical therapist. Another thing could be as well if you're part of any sort of support group, particular to Parkinson's disease, seeing if anyone else has resources. I don't know of an online directory of personal trainers that specialize, so the one exception to that I will say is that the Power Moves, again, that PWR exclamation mark. Let me see what that let me double check what their website is here. I think I'm not sure it's Power Moves, Power for Life, that's what it is. So PWR, the number 4, life, LIFE.org, powerforlife.org. They have a directory of anybody who's been trained in their Power Moves, and they have a therapist training. So for medical, more the medical side, like physical therapists, they also have a separate training for personal trainers and more community-based exercise. So if anybody's gone through that, they should be on their directory.
Thank you.
Mm-hmm.
Yeah, whenever I did check with the PTs to find out recommendations, those were mostly personal friends that they worked with outside the profession.
It might be,
thank you for that.
It might be, and it's worth checking out. The other thing too is every clinic in physical therapy operates differently in terms of how much time is dedicated to you, or what payment might be, what insurance is accepted. So you may also, I'd encourage you to also call around a little bit and see if there's any difference. For instance, in my clinic, again, I work there, I obviously like it and promote it, but it's we get an hour one-on-one. And so, I've had other places where it's 30 minutes. And so it really varies based on the clinic. So I'd also encourage you to call around and see if there's anyone else in your area that might be more available to give you more time.
Thank you.
Mm-hmm.
Okay. Any other questions from anybody?
So again, if you realize you have a question later, please feel free to reach out. That's my email at the bottom, that boulderbrainpt@gmail.com. I would love to answer any questions about the presentation, about your journey with exercise with Parkinson's. So please feel free to reach out. And then again, looking for physical therapy, that's where I work. That's the website, Rehab Without Walls. And I'd like to thank Parkinson's Association of the Rockies for having me again. Always love doing this, love the education side of what I do, especially with Parkinson's disease, because there's so much research that shows how beneficial this is. So it's really exciting. It's exciting to be a part of this world, and to hopefully encourage you all to start exercising or keep exercising.
Do you mind if I send everybody the presentation through email?
Not at all.
All right, sounds good.
So I'll email it to you, Annie, then for you to send out. Yeah.
Perfect.
Okay.
Excellent job. Thank you so much.
Thank you, everybody. Have a good evening.
Thank you.
Thanks. Bye-bye.
Thank you.
Thank you.